This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the journal Acta Neurochirurgica, published in 2026. The paper is titled Nerve Dissection Technique to Optimize Functional Outcome, Resection of Cystic Vestibular Schwannoma, How I Do It, authored by Mohammed Hassan and the senior author, Dr. William Cudwell.
This is a How I Do It technical note, which is often the most practical kind of literature for our residents and practicing colleagues. It focuses specifically on the Cystic Vestibular Schwannoma, or CVS. Alara, for the medical students listening, why does the cystic nature of these tumors change the surgical calculus so significantly?
Well, as the authors point out, CVS presents a much higher surgical challenge compared to solid tumors. The hallmark difficulty is the obliteration of the arachnoid plane. We usually rely on that plane to protect the brainstem and the facial nerve, but in cystic cases, that corridor is often lost. The paper mentions that cystic degeneration, repeated microhemorrhages, and chronic inflammation promote peritumoral fibrosis. This leads to structural instability and adhesions that make the tumor very sticky.
Exactly, and that stickiness is a nightmare when you're dealing with the facial nerve. The paper notes that the nerve is often displaced anteriorly or superiorly, stretched into a thin, ribbon-like structure. Sometimes it even splays through the tumor itself. If you lose that arachnoid sheath, the nerve is incredibly vulnerable.
The authors specifically discuss three common approaches: retrosigmoid, translabyrinthine, and middle fossa. But this study focuses heavily on the translabyrinthine approach. Dr. Aris, in your experience, why would the senior author advocate for the translab approach specifically for these cystic lesions?
The paper highlights two main reasons. First, the translabyrinthine approach allows for early identification of the facial nerve in the distal internal auditory canal, or IAC. Second, it essentially obviates the need for cerebellar retraction. However, the authors are very fair. They admit it has its downsides. It requires extensive temporal bone work, abdominal fat harvesting for the closure, and it's contraindicated in patients with high-riding jugular bulbs or poorly pneumatized mastoids.
Right. They mentioned that preoperative imaging is crucial to check for those anatomical constraints, like an anteriorly positioned sigmoid sinus. But once the approach is selected, they walk through a very specific case: a 59-year-old man with a 2.9 centimeter partially cystic lesion, causing mild brainstem compression.
Let's get into the How I Do It part of the paper. This is where the technical pearls are. The first step they describe is the skeletonization of the IAC. Alara, what was the extent of that decompression?
They performed a 270-degree decompression of the IAC after the mastoidectomy and labyrinthectomy. But the most interesting part of their strategy, I think, was the timing of the cyst management. Many surgeons might want to aspirate the cyst immediately to gain space, but these authors did the opposite.
Yes, that's a critical point. They deliberately delayed cyst deflation. They waited until the tumor architecture, the dissection planes, and the neurovascular structures were clearly defined. Why do you think that is, based on the text?
It seems to be about maintaining the structural integrity of the tumor while you're finding your landmarks. If you deflate too early, the walls collapse and the anatomy becomes even more distorted. They specifically mentioned that once they did start debulking, they used ultrasonic aspiration on the solid components. This re-established safe corridors by altering what they called the internal resistance dynamics.
I love that phrasing, internal resistance dynamics. It describes how the tumor's tension changes as you remove volume. As the solid part is debulked, the surrounding structures shift, which the authors say requires frequent spatial reassessment. You can't just assume the nerve is where it was 5 minutes ago.
And when they got to the actual dissection of the nerve from the tumor, they were very specific about the technique. They emphasized sharp dissection with microscissors and suction, especially near the trigeminal nerve and the superior pole where adhesions are densest. In areas where they lacked a clear plane, they didn't just push through. They adjusted the dissection angle strategically to minimize the risk of fascicular injury.
There's a specific maneuver they describe in the results section regarding the tumor capsule. They suggest leaving a thin rim of capsule on the nerve if necessary, using a fine hook and countertraction with soft cottonoids. The goal is gentle elevation of the tumor capsule away from the nerve while applying minimal traction. That's the secret sauce for House-Brackman Grade 1 outcomes.
Speaking of outcomes, the results in this case were excellent. They achieved a gross total resection, or GTR, without any brainstem violation or significant bleeding. But for the residents listening, the most reassuring part of the paper is the post-resection neuromonitoring.
Right. They stimulated the facial nerve post-resection and it responded briskly at 0.02 milliamps. For those who aren't in the OR every day, 0.02 milliamps is a very low threshold, which indicates the nerve is in great functional shape. And indeed, the patient had House-Brackman grade 1 function postoperatively.
It's also worth mentioning their closure, since the translabyrinthine approach carries a risk of CSF leak. They performed a multi-layered closure, which they note can make the leak rates rival those of other skull-base approaches.
To wrap up, what are the key takeaways for our colleagues? First, cystic vestibular schwannomas are a different beast than solid ones because of the loss of the arachnoid plane and the ribbon-like stretching of the facial nerve. Second, the translabyrinthine approach offers the advantage of early distal nerve identification. Third, and perhaps most importantly, delay your cyst deflation until you've identified your planes.
And finally, use sharp dissection and be prepared to leave a microscopic layer of capsule if it means preserving the integrity of the nerve. Minimal traction and gentle elevation are the phrases to live by.
This is a great reminder that even with anatomically distorted and adherent lesions, gross total resection is possible while preserving neurological function if you have a deliberate technical plan.
That's all for today's episode of the Neurosurgery Hub podcast. I'm Dr. Alara.
And I'm Dr. Aris. Join us next time as we dive into more practice-changing neurosurgical literature. Keep learning, and we'll see you in the OR.